Welcome to With All Due Respect. This is a podcast for women over 40 who are looking for sane, frank advice about their health and wellness, especially through and after menopause. I'm Amanda Thebe, a personal trainer and nutrition coach, and the author of the best-selling book, Menopocalypse, How I Learned to Thrive During Menopause and How You Can Too. I'd love you to join me every week as I chew the fat with some fab guests on hot topics that directly impact you. I also know the power of conversation is lost, and there's nothing better than sitting down for a natter with your mate and putting the world to rights. And that's exactly what I'll be doing with this podcast. We'll really get to know my guests, warts and all. I've made it my mission to help you by exploding a few myths and presenting you with plain, simple facts. These inspiring conversations will hopefully empower you to be a healthy, strong, resilient bitch, just like me. Before we get started, don't forget to hit subscribe and leave a review, and then visit me at amandathebe.com. And now let's get started on today's show. In this week's episode of With All Due Respect, I'm sharing a pre-recorded interview that I did with Dr. Jen Gunter. She is an OBGYN and menopause expert and is, in her own words, appropriately confident. I absolutely love Dr. Jen Gunter and have become a firm friend of hers. We did this Instagram Live at the end of Menopause month in October, and we spent the time answering questions that you sent in to us, and it was such a well-received interview that I've decided to share it with you here. So I hope you enjoy. Bye for now.
Hi Jen, I made it. So I've been motivating you to do some push-ups. I like it.
Every day I'm like, I spent a lot of time curating my Instagram feed. And I actually think this is probably one of the best pieces of sort of social media advice I think people can do is, so first of all, whenever I see people promoting scammy stuff, I just block them. So then I don't see them in my algorithm. I don't get contaminated. But I also fill my feed with people like you who are really fantastic ambassadors for health and fitness, because it motivates me, right? So if I haven't done my exercise in the morning, and then because you're 3 hours ahead of me, I see that you've been out for a walk, and then I'm like, okay, I got to do it. And
one of the things as well is it's trying to find the balance, isn't it, Jen, between being someone that's motivating and not being someone that's sort of too cocky saying, yeah, look at me, I'm exercising, what's your excuse? Because that's not what it's all about. It's like, here's some things you can try, and the little bits often is what we're always talking about, right? So, and I know you talk about how important exercise is during menopause, right? It's so important.
Oh yeah. I mean, I always say, like, if you could only do one thing, you're stuck on a desert island and you only have one treatment option available to you, it would be exercise, because it just touches so many domains. It touches mental health, cardiac health, respiratory health, bone health, musculoskeletal health. So it's the thing, I always say if exercise were a pill, we'd all want to take it.
Yeah, I know that in the UK now, the medical advice they give now actually includes to do strength training twice a week now, which is great, right? They've included that. So when I put the question out for this to my followers and your followers, there were so many questions. Oh my goodness. And so I thought we could do some sort of quick fire sort of answers, but I chunked them into different categories because there were so many questions that were quite personal. And so really it's easier to make them more generalized because these are things that we all want to know. So when you're ready, let me know, Jen, and I'll start throwing things at you.
So yeah, I mean, I think it's just good to say that one, it's never possible to answer personal questions in this kind of format. I mean, one, it's just not appropriate, but two, I mean, we need more than a one-liner about someone's health. So, but I know, I absolutely get it. And I think that I absolutely understand because people have so many questions, they don't know where else to turn.
Exactly.
So yeah. Let's see what you got. And then I have a couple of other things that I want to talk about at the end.
Yeah, well, just call me if I talk too much. The first one actually would be really interesting to know the difference between HRT and MHT, because there's people follow us both from across the ponds and we hear different terminology. So can you clear up the confusion around the terminology?
Yeah, I mean, I think it's really more of just a cultural thing, and the fact that maybe the UK hasn't quite caught up yet with the change in terminology, because we're really not, it's not appropriate to say hormone replacement, because it's not, your ovaries are not meant to be making estrogen for your whole life, right? So this idea that you're replacing something when you're 60, your 60-year-old ovaries were never meant to make estrogen. This is not like thyroid disease, right? Where it's a disease and you need to have that hormone for your whole life, or very serious things can happen. And so it's very appropriate to call it replacement therapy for someone with primary ovarian insufficiency who's 35, their ovaries have stopped functioning. It would be appropriate to call it replacement therapy if someone's 40, had their ovaries out, because we recommend taking hormones till the age of 50, 51, 52 if you go through things prematurely. But if you're 45 and up, HRT, I actually think is an offensive term, because it's implying that menopause is a disease. So,
or a deficiency, which is, I know, something we both really don't. It gets our heckles up, doesn't it?
Well, it's
wrong.
It's false advertising. And I think that I only see that term used by people who have something to sell. And sometimes that thing to sell is hormones, right? And they're trying to sell their fancy private practice, or they're trying to sell their laser therapy, or they're trying to sell their special G-spot injection that's never been tested. I mean, or their special diet, all these things. And just having symptoms recent enough to be treated, you don't have to make it a disease. But obviously, it's offensive to say that half of the population are going to live half their life in a disease state. Like, that's just unacceptable to me.
So the MHT just stands for menopause hormone therapy, right? And it's just a little bit more of an accurate term, essentially, isn't it?
Yeah. And again, just because we're all affected by the words we use. And I write about this in the Menopause Manifesto. If we look at languages that think of that where they have gendered nouns and bridge is female, people who grow up in that culture will think of they'll use terms like beautiful and elegant to describe a bridge, right? And if they grow up learning that bridge is a masculine term, they describe bridges as strong and powerful. And so our words can actually affect how we think about things. And so if every single day you're calling what you're taking hormone replacement therapy, you're subconsciously or consciously basically reinforcing a disease model every single time. So
that's actually what they say. I see women say, well, I'm replacing my hormones. I'm replacing my hormones because I'm going to be deficient. I actually get really offended by that, because I'm postmenopausal now 4 years. I went through it sort of early and don't feel deficient or diseased at all.
I'm taking it to prevent osteoporosis. So, and that's because of a genetic risk, right? So I think that to call it a disease, it's just not right. And it's unnecessary, right? Like, there's enough people who need help that you don't have to make it to sell your wares, I guess.
Yeah, because it works for what it's supposed to work for, right? And so actually, I've got a couple of questions about hormone therapy. So I'm just going to sort of generalize those a little bit. Well, the first one is, do I have to wait until my periods are missed, or can I take it anytime? Because I do have symptoms and I'm in peri-menopause, but obviously the periods haven't changed, and we see that a lot, right? So
yeah, so I would say it depends. So sometimes people have symptoms and they think that they're the menopause transition and they're not. And sometimes they are. And so obviously, so we'll assume they are, because sometimes I get people asking who are like 34 and 35 who have regular periods spot on every month. And that's probably unlikely to be an early menopause transition. I'm not saying it's impossible, but the odds are very low. So say you have somebody, so we'll take somebody who's 44, 45. And you're starting to get a little bit of period irregularity and you're having really terrible hot flashes. Yeah, you can absolutely start menopausal hormone therapy. If you want to, you can try other things as well. The only issue with starting when you're still menstruating is sometimes it can cause havoc with your periods and you can start bleeding all over the place. And so that's the only thing. And so you just have to keep that in mind. And so some people choose to use hormonal contraception with estrogen because you can get period control from that because you have a higher dose of hormone. You don't need that dose of hormones for menopause symptoms, but some people are like, look, I don't be bleeding all over the place. And some people start to get very irregular periods and they say, well, listen, I've got these really irregular periods on top of that, so maybe I'm going to use the birth control. And some people say, look, I'm going to get a hormonal IUD put in place so I don't have to worry about my periods. And then I'll see how I feel on a low dose of, menopausal hormone therapy. So yeah, I think that's one of the big myths, is that you can't have symptoms that are bothersome until you've had your final period. And that's not true.
Okay. All right. Yeah, that makes perfect sense. Hey, so Actually, while we're talking about hormone therapy, can we just switch over to progesterone? Because that's actually one of the ones I got most questions about, not the estrogen side, but the progesterone side. And so, the first one is about if someone has a hysterectomy but still has their ovaries and they've previously been on hormone therapy, the progesterone has been helpful for them for their sleeping. Is that something they can continue to take because they've found that it's helped with their insomnia?
Yeah. So progesterone is only needed for menopausal hormone therapy to protect the uterus against endometrial cancer, because estrogen is cancer causing. It is. If you take enough estrogen, you will get cancer of the uterus if you don't take enough progesterone to balance it. And so, so if you don't have a uterus, you don't need the progesterone. But when we're talking about a sleep aid, so that's not really menopausal hormone therapy. That's taking progesterone for sleep. And so, because when we're talking about MHT, we're really talking more about like hot flashes, night sweats, and things. And progesterone's not approved for sleep, but it certainly can help. And there's studies that show that 200 to 300 milligrams a day can be helpful for people. And so it can be worth a try, especially in the menopause transition. Now, some people feel awful on progesterone and they don't like it. And so I always tell people, you are not married to this drug. There's an easy divorce. You just flush it down the toilet, right? Oh, too bad divorce wasn't all that easy, right? I know that as a 2-time divorcee. So.
Yeah, which was that. If you haven't been divorced at least once, I don't want to know you. I called it my practice one.
Well, that's why I'm not getting married this time. I'm really bad in marriage. I'm really great partner anyway. So.
I like that. That's so funny. Talking about that though, like the progesterone not feeling good on it. So many people were like, I feel shit on progesterone. I felt shit on hormone therapy in general. And I know that that's me. And I know that I try and sort of wave that flag to sort of say to women, not everyone feels good on it. But why is there such a thing as a progesterone or estrogen intolerance? And do we know if there's any link to like someone having bad PMS or PMT during their lifetime or any other hormone sensitivity things like pregnancy? Does that make sense? Yeah.
Yeah, I think I would say certainly if anybody told me they had problems with hormonal contraception before, I might think a little bit about it, but you have to understand, as long as you're being dosed appropriately by a trained practitioner, you shouldn't be on doses that are approaching the pill. I mean, this is something I was thinking about talking earlier. I've heard from several people some shocking doses of estrogen that are the same as the high dose of estrogen in the pill when it's like 50 microgram pill. It's ridiculous. So when we're talking about doses like that, lots of people feel awful because the 50 microgram pill is awful. So if you're talking people using like 400 micrograms with a transdermal patch or 4 milligrams orally of estradiol a day, you'd feel awful on that, or you might. But if you're taking even the lower doses, everybody's different, right? I mean, some people feel I feel terrible on an antihistamine. People tell me it's not sedating, and I'm like, but I'm also someone who no other medication makes sleepy. And what we're learning is we all have slightly different ways that we metabolize medications. And so we don't have tests for that. So I would just say you have to kind of go by your experience. And sometimes there's medications that make some people feel worse and some people don't have that experience. I usually say though, sometimes it's good if you can, if the side effects aren't too severe, is to try to give it a 2 or 3 month try, because sometimes these kinds of side effects do go away. I mean, obviously if you're feeling just abysmal, then that's a different story. But if the side effect is kind of mild or, maybe mild to moderate, is it worth it for you to try to stick it out for a couple of months just to see if that settles down? And that's obviously a case by case. But some people, I have people who do great on menopausal hormone therapy and could never take a pill and vice versa. I do hear a lot from people with PMS. And I do think that a lot of symptoms in the menopause transition are mistaken as menopause when they're actually really a worsening of PMS that can happen in early menopause. So if you just add estrogen, that's not going to help PMS. So I think that's an important thing, because in the early menopause transition, what happens is the cycle starts to get a little shorter, and you shorten the follicular phase. So percentage wise, you're spending more of your cycle with PMS, right? So if you're spending 20% of your days with PMS and then you go to 30%, like that's a noticeable difference for people. And for a lot of people with PMS, it's the up and downs of the hormone, not the actual level. And the menopause transition is associated with that hormonal chaos. And so I do think that's a lot of the suffering for a lot of people early on as well. So yeah, I think you just don't know until you try how it's going to work out. We can make educated guesses, but that's about the best we can do.
And then it's just trying to find that good relationship with a medical professional, right? Because I know a lot of the times that a lot of women don't have the ability to go back and forth and just say, can we adjust things? And then, so what about like people sort of like me that tried everything and it wasn't meant to be, and that's fine, but still maybe are struggling with the vasomotor symptoms, the hot flashes and the night sweats. What other alternatives are there? Because that seems to be, we have a dog loose.
That's my dog. It's my big chocolate lab. She's so sweet. She never comes over to Instagram Live, so there's clearly there must be a cat in the front yard.
So is there other alternatives that they can consider? Just because you shouldn't have to put up with like life-altering symptoms, right? Because hot flashes can be miserable, right?
Just hang on one second. Oh, there's somebody at the door. I'll be right back.
I'm going to keep you all entertained while Jen's at the door. Because one of the questions was, I'm a little bit more outspoken about the Zoe app. The Zoe are doing these amazing studies trying to look at the best sort of food and exercise for women, but it seems to be heavily towards intermittent fasting and potentially changing our gut microbiome and wearing continuous glucose monitors. And part of me is like, while these can be potentially helpful for women, like the outcomes, we don't all need to be doing intermittent fasting, and we definitely shouldn't be wearing continuous glucose monitors, which are a medical device for diabetics. So I did a post on that recently, if anybody's interested in like following up on that, but I'm sort of just watching the space. I'm talking about the Zoe study on intermittent fasting and getting them to wear glucose monitors, and I'm just a little bit about that. I don't think that we need to be doing that. It's micromanaging our diet when we don't need. Most women, when I speak to them, aren't doing like the most basic things, like eating enough vegetables, eating enough proteins and grains and fats. And most people, when they start changing that, feel better quite quickly.
Yeah, I think a lot of these sort of people pushing that expensive technology, first of all, they have something to sell. So
yes, they do. Yeah.
And they're either selling that product or they're selling a coaching service or diet that goes with that product. And there's zero data to suggest that that's beneficial for people who don't have diabetes. I mean, it's just not something that's necessary. You normally have glucose excursions right after you eat something. That's how we evolved. And I would tell people, when I was doing my podcast and I interviewed, one of the world experts on metabolism, who'd spent time with the Hadza in Tanzania, 30% of their diet is from honey. So this sort of fear, this irrational fear of sugar and carbohydrates is really completely manufactured by the dietary industrial complex or the weight loss industrial complex. It's ridiculous. So that's what I have to say about that.
Yeah. And if we are and carbohydrates are our body's most preferred fuel. And if it had the choice between fats and carbohydrates, it would go for carbohydrates every time, glucose. And so why are we denying ourselves like the body's main fuel source? Okay.
All right. So you asked a question about other things. Yeah. So there are great options. So first of all, cognitive behavioral therapy is actually really effective for hot flashes. It's so fascinating. And what I find really interesting and also sad is that there's so many things that cognitive behavioral therapy is very effective for. It's very effective for hot flashes. It's possibly the most effective therapy for insomnia, CBTI, and it's probably the most effective therapy for people who are struggling with a desire disorder. Right. And the data is so good, especially for insomnia and for desire disorders, but it's hard for people to access it. So I want to give a plug for Dr. Lori Brotto, who I just did the live with her the other day about her workbook. So you can actually do CBT at home if you're suffering for that. But there's also medications because those programs aren't always available or they don't work. Or it's just not something everybody can do. Yeah. So for hot flashes, medications like venlafaxine can be very effective. So there's certain antidepressants can be effective. And gabapentin, I have a lot of success with gabapentin. And maybe because I do a lot of chronic pain in my practice, we prescribe gabapentin a lot for pain. I'm much more familiar with it than I think maybe a lot of other gynecologists. But even in a low dose, it can be very effective for hot flashes and also very effective for sleep.
I was on venlafaxine and actually helped me with my migraines too. And I don't know if it was meant to, but my migraines were managed as I had depression as well. And so it just got me through a really bad patch, and I was super thankful, that there was alternatives available.
Right.
So, there's people reach out to me, probably you as well, and they're in their like late 50s and they're still having periods. And they're still like, everything's normal. They don't even feel like they're in perimenopause. And so they haven't reached postmenopausal state. And one of the questions, a couple of questions came up like this, were like, are there any repercussions to actually entering menopause later? Because we always hear about that women have, like, we need to take care of those that go into early menopause. But what about those that go into late menopause?
Right. So later menopause is associated with a lower incidence of osteoporosis and a lower incidence of heart disease, but a higher incidence of breast cancer. There's always two sides to the estrogen equation. And so what I usually tell people is there are people who are, the average age of menopause is 45 to 55, right? So you're going to get like 95% of people kind of in that bell curve. But there are obviously going to be like 1 to 2% of people on either end that sort of tail out. So it depends kind of on the situation. Sometimes people can also have very irregular bleeding, and they kind of brush it off because they're not really paying attention. And so I would just caution that anybody who's over the age of 55 who thinks or believes that they're still cycling very regular, I would actually recommend maybe doing a menstrual diary for 2 or 3 months just to make sure, because every now and then we catch somebody who thought they were having regular periods and they weren't. And actually the bleeding was the warning sign for endometrial cancer. So once people get sort of really far out, you kind of have to start individualizing that. And of course, it's always a possibility that there are people who are going to go through menopause at 57 or 58, but those are going to be the outliers. And so in medicine, common things being common, you're like, you want to say, okay, well, what else could be going on just to make sure we're not missing something else?
Like cover all those bases. And as well, because something like that is really hard to like treat, isn't it? If people do get endometrial cancers and stuff, the gynecological cancers.
Well, it's very easy to treat if we catch it early. That's one of those cancers you catch early, you have a hysterectomy, you're done. Like that's it, you're done. And even if we catch it, and there's been a little bit of spread, but we have to do a few other things, there's still actually a really good survival rate for most people. So,
that's misunderstood.
Yeah. So getting it early is actually it's always better when you catch cancer early. Yeah. But this is one of those ones that like you can do it and people can be like, oh my gosh, I just had to have surgery and that was it. It's great. You don't want to have cancer, but if you have to have it, that's the one. So you just want to make sure that you're not missing. And on the flip side though, too, again, if you're 46 or 47, if your periods are all over the place, it's not always menopause. Sometimes it's endometrial cancer, or precancer. So that's why it's always a good idea to share what's going on with your medical provider so they can look at your risk factors and decide, oh gosh, this sounds like something we should investigate versus this sounds like something that sounds normal.
And some people still get bleeding when they're on hormone therapy, right? And even if, let's say, on a continuous progesterone, and if they get regular bleeding, is that okay? Like, is there anything that they need to look out for? Because there's a lot of bleeding questions we're getting sent to us, and I think it's like, what's normal bleeding on hormone therapy and what's not normal bleeding?
Yeah. So when you first start it, in the first 3 months, it's not unusual to get some irregular bleeding, and even the first 6. But again, you have to put that in context. So if I was starting someone who had a baseline higher risk of endometrial cancer and she got some bleeding, I might not ignore that. I might not say, oh, well, we can watch that, right? So you always have to put it in context.
Right.
So if you're on continuous, you really shouldn't be getting bleeding once you're past those 6 months. If you're taking it cyclically, then you will probably be getting a withdrawal bleed for some time. Often over the years, it reduces, but everybody's different. But often, by year 2 or 3, it gets much later, but it's still inconvenient for a lot of people. I wouldn't want to have a period when I was 58. I'm 56. I would hate it. I love now that I go traveling and I'm like, no period products to back. I mean, you'd be climbing the steps of the Amalfi Coast and then you're just like, oh my God, it's party at the Red Roof Inn.
I know. And we've all had those like times when we're out, we're like, oh my God, I feel like you're just going to, I called it like the alien expulsion. It was just like, oh my God. So There was a great question that came up. I don't know if you saw, and I think I'd love you to talk about like the GSM, the vaginal issues, and then what's like an appropriate treatment. When should we start? The dosage and just the things that we should be doing, because like we're all probably going to have that, right? Or some sort of it.
Yeah, I mean, it's really interesting. There are people who are never on any estrogen and they come in, and maybe they haven't had sex for a long time. Maybe they're widowed and, or they're just somebody whose maybe partner has erectile dysfunction and they're just decided that, or treatment might not be possible for the partner, whatever reason, or they're unpartnered for another reason. And you look and their vaginas, like, they look just like they're fine and they're 75 and you're like, and then you see people who come in who are 46 and they're still having some periods and their vaginas look like they're dry or they have these physical changes that we associate with genital urinary syndrome and menopause. So it's really not possible to predict. But many people, especially people who want to have penetrative intercourse, will have symptoms. And also at the age of 60-ish, the risk of bladder infection starts to rise. And vaginal estrogen can help prevent against that. So there's lots of reasons to be on it, especially considering it's very safe as long as you're taking a pharmaceutical dose, right? So it's basically a local therapy for a local issue. And that's sort of the best in medicine, something that's not going to get elsewhere in your body and cause other problems. Yeah. And there are tablets, there's suppositories that are like sort of in sort of gelish capsules. There's the ring, there's the cream, and there's also something that is DHEAS, which is converted by your body into estrogen. And they're just all different options, and that's called progesterone. And they're just all different options and delivery systems. And so people who've had irritation before with different vaginal products often do great with the ring because it's just the hormone seeping out and you just put it in, you change it every 3 months. Some people love the feel of the cream because it's very soothing. And especially people who have more irritation out on their vulva. Yeah. The vaginal products don't often treat that area. And some people find that they can't stand the mess of the cream. They don't like the idea of a ring and they love the tablets that they pop in. And so I think this is one of those situations that it's great to have a bunch of things on the menu because touch and feel are very personal and you want what works for you. And so the only thing is it's going to take 6 to 8 weeks for you to see an effect. And basically everybody can use vaginal estrogen. It doesn't matter as long as you're not using a compounded product because those can have higher levels of hormone. And then we have issues figuring out what's safe for you. But if you're using a pharmaceutical product in the doses that are recommended, we don't have to worry about it overstimulating your uterus. We don't have to worry about it doing anything. And really the only people who really need to have a discussion about safety are people who are on aromatase inhibitors who have estrogen receptor positive breast cancer. We believe overall that for most people in that situation, it's probably safe, but we don't have the greatest data. And so it's really important to have that conversation. When people are using tamoxifen, if there's any estrogen that gets in the bloodstream, the tamoxifen can block that. But with aromatase inhibitors, because they work differently, it can't block any estrogen that gets in the bloodstream. So I think that's something that you have to have, that requires a very individualized approach in the office.
And then for those who have had ER/PR positive breast cancer and now have that lichen sclerosis, is that something that they can use, or is there other treatments they can use for that?
I think that's too complex to answer at all in this situation. Yeah. So that would be something that you would have to, because you have to know what somebody's, recurrence risk might be to have that conversation with them, to know how many years out they are. So there's a lot of nuances. So for someone like that, I would recommend they're seeing somebody who knows about both lichen sclerosis and menopause.
Yeah, it's this finding this team, isn't it? This medical support team that just really want the best for you. And that's sort of one of the things that women say to me, they're still having to fight their GPs. Jen, they want to go on menopause hormone therapy. They're ready. They're symptomatic. Their quality of life is impacted. But they're still getting rejected by GPs because of the WHI study. Do you have sort of any words of advice on how to even just approach that with the GPs and how to have that conversation so that it's sometimes hard enough to build up the courage, isn't it, to have that conversation? Then just to get shut down, it's just demoralizing.
Well, what a lot of people do is they use my book at the doctor's office. It certainly works for a lot of people in Canada because I'm so well known up there. And they're like, oh, hey, Jen Gunter says this, and I seem to fit in this category. Is there a reason? And so print off if you're in England or the UK, print off the British Medical Society's guidelines. So that's, I think, the best way around it is, go to whatever country you're in, go to the British Menopause Society or the North American Menopause Society or the International Menopause Society, and just print off the guidelines and find the section that fits you, and then take it to see your provider. Now, it's entirely possible there's something going on that your provider maybe has not communicated appropriately. So, for example, if you are a very high cardiac risk, if your ASCVD score is 10% or higher, we don't generally recommend going on menopausal hormone therapy, right? So there, if you have a clotting disorder, so there might be some situations that might be very specifically applying to you. And so, but it should also say, it says that in the guidelines though, right?
It does say them
yeah. So,
on my website, amandathebe.com, I actually have one page that's resources, and I have every single country's that I could find, their prescription guidelines and consensus statements. And in Canada, there's one from Sigma, which is the Canadian Menopause Society, and it's called the Pocket Guide to Prescribing. And I actually know the woman who wrote it. It's brilliant. And I literally would print that off and say, take that to the doctor and go, there you go.
Absolutely. Yeah, there's the Australasian Menopause Society. And you know what? The guidelines are all almost identical. There's maybe some minor nuances, but that's just based on generally product availability locally. So the fact that you have the International Menopause Society, the North American Menopause Society, the British Menopause Society, the one in Canada, the one in Australia, that they're all on board the same way, it really tells you those guidelines are robust. And I think that if your GP still looks at that and says, well, I don't believe that, then, and doesn't give you a valid medical explanation, says, oh, hey, but you have this liver condition and your liver specialist told me this. So taking those things out of it, then I think it might be time to get another provider. Someone also mentioned the NICE guidelines, and there's also another one too. Yeah. So they're all basically the same.
And so when these joint position statements or the medical consensus are released, Jen, it's based on them looking at all the studies, right? They gather all the studies and then make their position based on that. So I want to bring this up, because I think it's really important that you and I see that, claims are made that breach those medical consensus, breach the position statements. And so for somebody like me, who is not a doctor, don't even play one on TV, and I'm knee deep in the menopause world. How on earth is Sharon down the street supposed to know who to listen to, right? It's just very confusing for a lot of women.
It is. But I also think that, if you're going to a private specialist who is just telling any doctor who puts you on hormones, I think people should still look these things up. I love when people say, I get emails from patients, oh, I checked what you recommended, and that's what the North American Menopause Society guidelines say. So I feel really good about it. That's awesome. That's fantastic. I don't have any issues with that at all. And I think you should be doing that for lots of different medications. Now, there's lots of things in medicine that we don't have hard science on for lots of different reasons. Right. But, for example, if you have chronic headaches, there's guidelines from the Headache Society. You know what? If you have type 2 diabetes, there's guidelines on that. And when people are saying, oh, well, I'm a maverick, or I work outside of the guidelines or whatever, I would say, do you want a pilot who's a maverick who flies outside of the guidelines? Do you want a pilot who's flying you through a storm and says, well, the Federal Aviation Agency says we should go around this storm, but I'm a maverick, we're going through it? Is that what you want? That's what I tell people. And, these guidelines exist for a reason, because some of the areas might be confusing or not, but, the studies need to be evaluated. And I've also had people say, oh, well, the guidelines are all pharma influenced. And, for menopause, they're not. Certainly people have to give their disclosures, but they're never recommending a specific product, right? No. They're not saying you need to take drug A. They're talking about classes of medications. And in most places, they're recommending generics.
Yeah, and when they're generic, they're usually provided by like Canada Health, they're approved by the FDA, and they're in the NICE guidelines, etc. So like there's tons of supplements and proprietary mixes on the market for menopause, and I do think women should be like buyer beware. I mean, I'm not against supplements. I think that there's certain things that like we do need as we get older. There's huge research there on magnesium being super helpful, and potentially some omega-3s if it's lacking in your diet, vitamin D potentially if you need it for osteoporosis with calcium, maybe depending on you. But like there's a few questions about, is there any supplements you recommend? And I remember speaking to Dr. Lauren Stryker, who said that there's one called Everall, I think I'm going to say, that's available in the US that NAMS have sort of approved and said that the studies have shown there's been some help with hot flashes. I don't know if you know about that one. I mean,
I think you mean, so first of all,
yes,
Esqual, yeah.
Esqual, yeah.
Yeah. So the data is low quality. I mean, there's probably no harm in trying, but the data is not great. It's not great like we have for other things. So, and the other issue with supplements is you don't really know what's in it, right? And so you don't actually know what their standardization process is at the factory. When I get my estrogen patch, I could walk in to the factory and have it stopped and have it pulled off. And you could guarantee that on any day it's being manufactured, that patch has exactly or within a really narrow margin of error, that amount of hormone. And when you are making supplements, you're not held to that standard. Could S-Equal have that same standard? Sure. Could it not? Sure, it could. So that's just always something people have to consider. That's why, and that's one of the big reasons I'm very anti-supplement, because you don't actually know really what you're taking. And researchers, so if we want to study S-Equal, so say we say, okay, I'm going to buy a batch and we're going to study it. I don't know the batch that I bought is going to be the same as the next batch that somebody else could buy, because they don't have that requirement for manufacturing, right? So, and again, they might. Maybe their product is fantastic. So because that information is not available, because it's not required, because there aren't like spot checks, you don't know. But so it's unlikely to be harmful based on what we know. And so that's something that people can try. There's also something called Relazin, which is some kind of like pollen extract. Again, the studies aren't the highest quality. I think NAMS is coming out with a statement soon on sort of these types of supplements. I don't take any supplement at all. And so the data on omega-3 is not really that good. If you don't get fish in your diet, then it might be helpful. So if you're someone who's not eating 2 servings of fish a week, then it certainly might be helpful. There isn't any recommendation that I'm aware of to take magnesium daily. So there's probably no harm, unless if you take too much, then you might get diarrhea, right?
Then you've taken too much, actually. Yeah, but if you want to go, it makes you go. It's like having a strong coffee.
So,
that's fair. I mean, it's an unregulated business. I appreciate that.
And then also, I mean, the Vital trial came out with vitamin D. And if you're not someone with vitamin D deficiency, there's no data showing that if you're just like an average person who's healthy, that vitamin D supplements make a difference for you. I think what people don't realize is that there's a lot of, I hate to say like dark money, but behind vitamin D, and how it became this whole thing in the 1990s and recommended for everything, and the wonder hormone, and really sort of latched on by alternative medicine. And there's been trial after trial after trial trying to find vitamin D helping something. So I would tell people to ask your individual provider and look at your own country's guidelines, because there are some different guidelines based on different countries, and that more isn't always better. So for example, calcium supplements are associated with kidney stones. So you want to make sure that you really need to be on them.
Need them. Yeah. That's fair. That's a really fair answer. And I think there's some generalized, someone saying that their doctor's telling them just to take it. Yeah. Because we're all deficient. And I listened to you did a podcast on this, right? And so I think that like for me, I have to take an iron supplement. I'm borderline anemic, but I only know that because my doctor told me with my blood work, right? So I think that like when you truly know you need to take something, then it's a different conversation, right? When
Right. The thing is, as I mentioned, guidelines change, but I don't know if actually, and I'm not up to date on the Canadian guidelines, but I don't know if Health Canada, I would look to Health Canada and see what they recommend. Do they recommend that every Canadian take a vitamin D supplement? Because do you remember a lot of foods are fortified with vitamin D as well, right? So it depends how much milk you're drinking and other things. So I think that basically the data shows if you're taking a low dose vitamin D, like 400 international units a day, there's unlikely to be any harm from that. We don't have that. That seems to be totally fine. And that's going to push most people, if you were borderline deficient, into the good range. But we definitely have some data that shows that the really high doses of vitamin D can lead to harm. So I do think it's just important to be aware.
Yeah.
And follow your country's guidelines.
Okay. Yeah. Brilliant advice. Okay. So I have so many more things we can talk about, but I do want to make sure that we cover the stuff that you want to talk about too.
Oh, fire ahead with a few more. That's great.
Well, one of them that made me laugh properly out loud was what's with this facial hair? I mean, I call it my Nanny McPhee. I feel like my kids are going to pluck hair out of my face, and then everywhere else has lost hair. Everywhere. So that's interesting, Jen.
Yeah.
What do we know about that?
Well, it's probably related to the fact that the testosterone that you're producing has less counteraction from estrogen. So that's probably it. It's always amazing to me, the hair is not there. And then the next day it's an inch long. You're like, what happened? How did that? So I actually have my children know that if I become incapacitated in any way and they're my caregivers, that they have to pluck my chin hairs.
Yeah, that's fair. I mean,
or I think get someone to come to the house to do electrolysis. But yeah, so it's probably related to that. Testosterone increases hair growth in your facial area, on your chest, all those types of things. So it increases hair growth in these other areas. And so it's not being counteracted by the estrogen. That's probably the best guess that I have. Why it's just the chin though, and not other places? I don't know. Maybe those hair follicles are more sensitive to it.
Yeah, it's really bizarre though, isn't it? Yeah, it's crazy. So somebody was asking about testing, and I know you've got some great advice on this, because where I feel like women get often failed by Western medicine when they go to their doctors, it ends up being the other extreme, that they'll then get too much time spent with the alternative medicine, the naturopaths, and test after test, and it's crazy the amount of money that they're spending. So what do we know about testing, Jen?
Yeah. So I would personally never go to a naturopath ever. They have half the amount of training that physicians have, first of all. So 4,000 hours versus 8,000. And I think it was, Unbiased Science Podcast. That's the name of it. They recently did a good review on it.
So great. That's what it's called, the Unbiased.
And so they have half the amount of hours. They actually believe homeopathy is real. And I always tell people, so that's like believing magic carpets are real. And if you had a choice between a pilot flying your plane, do you want someone who's done 8,000 hours, all about how planes fly? Or do you want someone who's done 4,000 hours, where a significant percentage of those hours were spent on how to fly magic carpets?
Have you seen that video clip where it's a British comedy where they rush into ER and it's the homeopathic one? It's so funny, if anyone, it's called, and it's exactly that. And when I first came to Canada after I had my first baby, was super tired, and I was anemic actually. That's what it ended up being again. And I went to a naturopathic doctor because we didn't have them in the UK.
Right.
And I went to this doctor thinking, a doctor that does natural things. This is 20 years ago. And I left, and it cost me $600 that I didn't have. And all I got was supplements and an empty wallet. And it wasn't covered by my insurance either. And so I just was like, what was all that about? And I physically was gagging taking these supplements. Right. And then I started to pay attention, and I was like, holy moly. And then I remember reading the website from Britt Marie Hermes. I think, is it called the Naturopathic Diaries?
Yeah, absolutely.
And it was, I was horrified by it. And so I just don't think that women need to feel like they need to go from one extreme to the other, right? I feel...
So naturopathic, I actually bought the main naturopathic textbook that they teach with. And my next project, when I finish the book I'm working on, is I'm actually going to do a critical review of it. It's horrifying, some of the things that they tell people. This is basically medicine from the 1820s, 1830s. It's like humorism. And this idea that you can use natural things and have the body heal itself. Well, if you follow that through to the end, that means it's your fault that you're sick. Right? Because you didn't harness your natural energy properly, you would have been sick in the first place. And then there's this idea that taking supplements is unnatural. I mean, it's not as if they're saying, hey, you should go. And so the only advice they were saying is go for walks. Here's some healthy diet recommendations. But they're not. They're telling you to take mega doses of supplements, which your body can't handle. And so my first advice would be, don't go to a naturopath. Really don't. I'm sure there's one or two good ones out there, but in general, if you're suffering, the other thing is hormone testing is not recommended if you are 45 and up. And it's just not. And it's a really hard thing for people to wrap their head around, because especially in the West, I think we all associate testing with caring. We really do. And this idea that we make a clinical diagnosis, right? So if you have migraines, there's no blood test to tell us you have migraines. We might do a CT or an MRI scan to make sure there's not a brain cancer masquerading as a migraine, right? And we might say, okay, well, want to make sure you don't have lupus or something else, but there isn't like a test to say, yep, you have migraines. We do it based on your history. And for menopause, if your periods are irregular and you're over the age of 45 and you're having hot flashes, you're in the menopause transition. Just like if you're 11 and you're starting to get breast buds and you're growing, you're in puberty. We don't need a puberty test. And so people who want you to do hormone levels, they want to be able to follow you so then they can charge you for keep doing the hormone levels, because they make money interpreting it. And it's not only that you're wasting money, you're getting worse care, because we do not do menopause hormone therapy based on levels. And so if someone is trying to push you to a certain level of hormone to make sure you're in the right zone, you're getting negligent care. That's all I can say.
And in Canada, I found out recently that the naturopathic medicine, it probably is the same in the US. I just don't know. And there's certain rights that they can prescribe certain things and not others. That they can't prescribe regulated hormones, but they can prescribe the unregulated ones. So women so they'll go and have compounded hormones, and then the testing has to be, they get tested every month, because we don't know if it's going to work or not, right? And it's actually, I find it exploitation. I think it's horrible.
Yeah. So in some states, naturopaths can't prescribe. This is very state by state. They're heavily supported by the supplement lobby. So because the supplements want them to be in every state practicing as a physician. In some states, they can call themselves physicians. In some states, they can call themselves doctors. In some states, they can call themselves a naturopathic doctor. But ND sounds a lot like an MD, doesn't it? And the level of medical care, what they offer as therapy is frightening. And I see this on a weekly basis, people coming in with all this battery of tests done. And I'm like, well, they ordered that battery of tests, then they should be the ones treating you for it. Because if I had a patient who I thought, ooh, I think you have a rheumatological condition, and I'm not an expert in that, I could probably order some of the blood work, but you might need extra blood work that I don't think of. So instead of me ordering some of the blood work and then leaving the rheumatologist to deal with what I've ordered and then the extra stuff, I'm just going to send you to that expert. Because sometimes, for example, there are tests that we order and the result actually makes it harder for the rheumatologist to decide what they should do. And so I want you to have the care from the expert. And so I'm not going to order that test. Also, if I order a test and it's abnormal, so say, for example, I order an iron level and it's really low, like it's 4 ferritin of 4. And I want you maybe to get IV iron. What I do is I contact your primary care doctor and I say, hi, Dr. So-and-so, I ordered this iron because my patient has this. It looks like she might need intravenous iron. Is this something that you feel that's the right course of action? And are you willing to do this? So I don't make my patient take that lab results. I do that physician handoff. And those are signs of good quality care. And I know that people love their naturopaths, and I know many of them spend a lot of time with people, and I wish I could I do actually spend a lot of time with patients in my office because of the way my clinic is structured, because I'm a specialist. But there has to be a better way than having people go to, what I consider to be predators. The other thing is, you can look up on the database to see how much money I get from pharma, which is 0. But you can't look up a naturopath to see how much money they're getting from a supplement company. And those naturopaths who sell supplements with their face on it or their name, right? They're like, they make up medical conditions like adrenal fatigue, and then they have supplements designed to treat a non-existing medical condition. It's such a scam. And I know I'm getting all worked up.
I know, yes, Jen Gunter getting worked up. I love it. But you know what? So but the same with the testing. I spoke to somebody who actually went through all of the training and the coaching, and the payback that they get for all of these tests. It's a multi-billion-dollar industry, that just the testing. And so even the ones the Dutch testing, right? I could give a Dutch test. Like it doesn't, it's crazy how on Instagram I'm seeing all of these like health coaches giving Dutch tests and analyzing the hormones and then collaborating with people to give and I'm just horrified. And the Dutch test is what, like $700 now? It's shocking.
If the person ordering the test cannot do the treatment that the test result requires, they shouldn't be ordering the test. They really shouldn't. Yeah. We're not talking about a physician doing a biopsy and it's coming back cancer, so now I'm going to send you on to the oncologist. Somebody who's not a licensed medical professional shouldn't be ordering these tests. And we see it all the time with the DNA tests and all that kind of stuff. And it's really concerning. And it sets up for a lot of conflict in the office, because somebody comes in and then I have to tell someone that those lab results are useless. And they've been told by someone that they need progesterone based on their progesterone level. And then I start explaining why that test is incorrect. And then now I don't have, that takes away from their appointment time. And then I get really angry because they spent all this money, and why won't I just help them? And I'm sure I get lots of people saying that I'm a mean doctor or a bitch because of that. And you try to do it in the nicest way. And sometimes I just have to say, you're going to have to bring that up with your naturopath, because that isn't what we do in clinical medicine. Here are the guidelines, and we're just going to have to move on, because I can't, you were given bad advice.
Do you ever say to your patients, bitch, I'm from Winnipeg?
No, I know.
No, I'm just talking.
Yeah, I know how easy it is to get sucked in.
I know.
And these people are so predatory, and they have their speech down, and it sounds good. Look, my partner, he almost got sucked into some alternative care for back pain, because that's a really hard thing to treat, right? And he went through the medical system and he got started with physical therapy, and it started to help. But then because he was starting to make some improvement, he was cut off. So he even tried Reiki, which has actually made his pain worse.
I can do it on the screen now if you want, because that's what they all do now. But I mean, that's actually a really great point, because none of this is to put blame on anyone. I think all of us have fallen for a little bit of something at some stage, because sometimes it's compelling, and when you're in pain and when you're lost and nobody else is helping you, it's easy to get sucked in.
Look,
for sure.
Scammers are really good. I mean, and it's not, they're becoming so advanced, right? I almost clicked on a text, so totally not even a medical related one, but it was from a bank that I used and everything. And then I was like, wait a minute, my bank doesn't text me, but it looked so legitimate, right? So it's the same thing. And, a lot of times these health coaches, I use that term loosely, and naturopaths don't even know that they're wrong. They actually really believe it. They believe it hook, line, and sinker. And I'd even make it so, which is worse. I mean, I had somebody on my Instagram the other day, someone from Calgary, prenatal and postnatal health coach, saying that the COVID-19 vaccine causes miscarriages. And so, I did a video about it. Looks like her Instagram account's disappeared now. And they obviously are making money off these kinds of lies, or why would they do it?
I think they think their own shit doesn't smell. That's why. Okay, so.
Let me tell you something. So whenever I write for a blog post or for another site, or, obviously all my writing for my books, I spend hours going through just to make sure the thing that I'm sure I was taught correctly was right. And this confidence that these naturopaths and supplement sellers and quasi coaches have is really something. It's really intoxicating, their confidence.
There's somebody we mutually follow on Twitter, Mallory, and she posts all of these grifters, these alternative grifters, and they're amazing. Actually, the way that they come out with it, they're just hardcore. Jen, recently it was the North American Menopause Society, and I know you didn't go, but you were sort of having a little look at things that were being discussed there. Is there anything worth sharing? I just was curious as if there's anything you saw that you were like, oh, that's going to be interesting to keep an eye on.
Yeah, I did a couple of days did it remotely, which is fantastic because every day it's like, is this worth getting COVID over or not? Right? Like every single thing we do, we have to make this like this sort of this weighing it. And I'm just big conferences inside are, I went to a conference recently in Hawaii, but we do like almost everything outside. So it was great. So there wasn't anything sort of brand new that to me from what I heard, but there was a lot of discussion about the importance of sleep, and that lack of sleep can certainly looks like it has vascular effects on the brain. And I think people are really trying to tangle out. We know that people have more hot flashes tend to have a higher incidence of cardiac disease and a higher incidence of other things. And is it really that the hot flash, is it cause and effect, or is a hot flash just a warning sign, right? And so people are really trying to tease that out, because certainly if you're sleeping poorly because of the hot flashes, does that explain some of the things? Or is it not actually related to the waking up? And is it that the hot flash is a marker for this other thing that's affecting your brain health or potentially affecting your brain health? So I think there's some really exciting work that's going to be teasing that out down the road, but there was a big emphasis on the importance of sleep. And so I think one of my parting messages would be that if someone asked if hot flashes and night sweats are just hot flashes at night. So, that if you're waking up multiple times during the night hot, that we want that treated. And if that's something that you can take, then some type of therapy for that might be beneficial for you. But not all sleep disturbance is related to hot flashes, right? And so I want people to remember that there's CBTI for insomnia, highly effective. Some people might need short-term sleep aids as well, or even long-term sleep aids. So just these things to, talk about, get screened for sleep apnea if you're waking up and sort of snorting yourself awake type of thing. Or if your partner thinks.
Also stress as well, right? Stress can impact our quality of sleep as well, right? So I suppose that's where the CBT comes into it as well, right? Like I think that it's everything.
Yeah. I mean, CBT is fantastic. I mean, one of the short tips I tell people is, so one of the big mistakes people make is when they wake up is they either go to their phone and then they read something that might like get them worked up. Like you check an email or you check your bank balance or something that's going to or you check Twitter. And so you get anked up, and then you check the time, you keep checking the time, you keep being worried. And so one of my psychologists years ago at work, my pain psychologist gave me this great advice, is that if you wake up in the middle of the night, and it's obviously not a hot flash related thing, you just kind of wake up, you want the clock turned away so you're not looking and you're checking the time. And you want to just lay there and try to sleep for what feels like 15 minutes. Might not be 15 minutes, but feels like 15 minutes. And if you're not asleep within 15 minutes, you need to get up and go to a very dimly lit part of your house, leave your bedroom, and get a boring book and start reading the boring book. And when you start to feel like you're falling asleep again, go back to the bed. Because what happens is people start to learn the lack of sleeping with their bed. And it becomes this learned association. Yeah. And time checking makes you feel anxious, and that's bad for sleep. And these things are easier said than done. Right?
Oh, I know. And it's getting the phone out of the room as well. When a lot of us use our phone for our alarm. And I've heard sleep experts say, get rid of the phone, buy an alarm clock. Turn it around, or have a notebook next to the bed that after you've tried to go to sleep for about 10 minutes, like write your thoughts down. It's almost like the disassociation, isn't it? And so and then just try some deep breathing as well. That's always I think breathe through everything also. It's just so good for you.
But there was a big emphasis on sleep, and Lori Brotto gave a fantastic lecture. And there was also a big talk about some really fascinating stuff, which I haven't read enough on to really talk about intelligently, but about the role of how the gut microbiome changes in menopause and how that may have more of an impact on things like osteoporosis than we think. And that was really fascinating. I was like, whoa. That was one of those lectures every time he said, I was like, whoa. And that one possibility is that the way estrogen might be helping people is that it's actually affecting the gut microbiome.
And there's cultural changes. Wasn't that part of it as well? That throughout the world, there's different where you live. Changes
that was a
different one.
That's from a different context. But actually, we talk about that in my podcast, Body Stuff, a little bit in the allergy episode, which people might find fascinating, a food allergy episode. But so it was really fascinating. And so this idea might then open up the possibility of probiotics as a treatment for osteoporosis, meaning a non-hormonal treatment, right? Now, that doesn't mean you should go out and buy probiotics now to prevent osteoporosis at all. I don't want anybody with that impression, but I think it's great to say, hey, do we really understand how estrogen protects bones? And if you think about how we were studying things in the 1980s, we couldn't do the type of analysis we can do today on gut bacteria, right? So as new technology emerges, we can start to find out new things. And unfortunately, it takes a lot of money and it also takes a lot of time to do some of these studies. But that was kind of one of those like, whoa,
that would be cool. It is a new science, isn't it? It's like one of those emerging sciences as well. And part of me is always just a bit like, oh no, someone's going to read that and then just start selling a menopause probiotic because they read it. Of course they are. But I'm just like, eat your fiber, at least like get some good prebiotic in your body, like eat your 25 grams of fiber a day.
And I think that kind of goes back to what you said earlier, that there are so many sort of basic health things to do that a lot of us don't do. And I'm a sort of a calorie tracker. That's me. I'm not saying other people need to do that at all. That's something that I do. And I do it because it allows me to go back and look at my fiber intake and my protein intake, because I'm trying to get my protein intake high enough because, I'm doing my weights. And I looked back because I was in Italy recently. And lo and behold, and I was like, travel constipation, right? It's the worst. And I went back and I looked, and because I had that data that I collected prospectively, I was like, oh, I was eating 12 to 15 grams of fiber a day when I was in Italy. And normally I eat 25 to 35.
Yeah.
Okay. It's really no shocker why that happened. And so I think that, so now when I go to Europe, I'm going to take my brand buds with me.
Yeah. Or your Benefiber sachets or something, stick them in your coffee. Yeah.
So I think that I think my point here is it takes work to get 25 grams of fiber a day in our society. It takes work to get your steps in, right? After we get off, I've been pushing it off all day. I'm going to have to go for a walk. The dog's like, So it's like work and effort, and it takes a lot of mental energy. It takes mental energy. I was at the grocery store and I was like, oh, I want to get a bottle of wine. And then I was like, oh, but you know what? You're trying to have less alcohol because it is really associated with a lot of negative health outcomes. So don't buy it because you'll just drink it and wait until the weekend. It takes mental energy to do that.
Yeah. And those little voices we have in our head are the ones that matter, like just taking that pause. I mean, this is the type of pause that we should be like celebrating, is where we stop and we go, am I hungry now? Or is this like the muffin time of day where I'm just walking through the kitchen to grab a cup of tea and a piece of cake? And so like those moments of pause and is just behavioral change, which we know is really impactful, right? I'm a huge fan of behavioral change, the small little things all the time. So I know that's what you do too. Yeah.
And it's a real conscious effort. And so I think that, like I said, it's just easier said than done.
Yeah.
And like, for example, all the data we know about alcohol being a carcinogen, and we know about it being linked with lots of different things. And so, but I also want to enjoy it now and then. And so for me, I'm making a conscious effort to save that for when it really matters. Like, for example, when I'm going to Italy and I want to try Aperol spritzes. So it just allows me to make those decisions. So.
Yeah. And people are like saying it's so nice that you have the same struggles as us. Of course we do. We have the same. None of it. Like I certainly don't wake up in the morning motivated going, yeah, I'm going to work out today. Very rarely. But I do it because I always enjoy it when I started and I know the benefits. It's just it's a win-win. But not many people, but it's like one of those things, it doesn't just come natural. It is work for sure.
And you getting up helps me get up to do it, because we mentioned at the beginning. Yeah, I mean, honestly, I need to get back. I want to get back into running too, because I really do enjoy it. And the pandemic derailed so many things for so many weird reasons. And I'm one of those runners, like, I hate the first mile. Like, I hate it. The whole time I'm like, oh my God, this fucking sucks.
Do you do like a routine before you go out where you go, I'll just go to the toilet one more time. I'll just do this. And it's like procrastinating running, I call it. It's like, you just don't quite get out the door. But then after like you've been out 10 minutes, you're like, I love this is fine. And then the last mile, you're just like, this sucks.
I don't actually think any time when I'm doing aerobic exercise that I've never had a runner's high. Like when I ran a marathon, when I did a half marathon like 5 years ago, I felt like I had a great sense of accomplishment. Don't get me wrong. When I was running and I was doing 10Ks on the weekend, I felt I had a great sense of accomplishment. But there was never once when I was out there going, oh my God, I'm so high from running. Like, I'm like, no.
This sucks.
But afterwards, every single time afterwards, my body felt better. And I liked that my body felt stronger. And I liked that, like, for example, when I do weights, I mean, when I see that, that Kim has like Bulgarian split squats.
She's so mean. Yeah.
Those are like, and like the back of my leg, like my ass is burning, like it's burning. And I mean, I don't enjoy that. Like there's no universe. Like I don't, but afterwards, you know what? I enjoy that when I went to the Amalfi Coast, I could climb up 115 flights of stairs.
Exactly. I saw that. But any of the Eastern European exercises that are in your program are always bad. I'm recovering from an Achilles injury that's in now like month 10 or 11. It's very frustrating, but I'm desperate to get running again because it's sort of my time away from the family and on my own. I like it. And I'm going to do another Tough Mudder. So Jen and I, we're going to do a Tough Mudder together. I've decided. Come on, you're strong now. You can do monkey bars and we'll get everyone watching to do it too. We'll have like a team of like 100 people. It'd be awesome.
It would be great, except that just seems like torture to me. And I don't know. I don't want to have to crawl under barbed wire in mud. That just doesn't, I mean, I don't need to go.
We'll have an Aperol spritz for you at the end. How's that?
I think there needs to be like an in-between. Like that's why I like half marathons because like the training for a marathon, it's like your whole Sunday is gone. And I don't want to, that's the other thing about aging. Like I have other things I want to do with my time. And it's great to do like maybe half the amount. So maybe there's like instead of like a tough mudder, do they have like a semi-firm mudder?
I'll look. People are saying it's fun to play in the mud. It really is. I love it. I'm like a pig in mud, literally, when I do it. But all right, I'll work on it. Don't worry, everyone.
I'm one of those people who hates to get like 1 grain of sand in her bathing suit. I'm just like, I think it's a sensory thing. I love walking in the sand, but if I get sand on my clothes or I don't know. I mean, maybe I'm a delicate fucking flower.
Well, that wasn't a no. So I'll take that as a maybe. I'm not hearing no. So that's the main thing. But I think we've got to wind it up now, Jen, because we've been on like forever, but it was awesome. Actually, I really loved our conversation. It was big. We talked about so many different things. I hope it was really helpful for everyone who was on here.
Yeah, well, I will save it and maybe we can do it again. We can chat about some other things that come up and other data and as they emerge. And I think it's just it's good for, I think really the great takeaway is we all have a lot of the same stuff going on, but 2 national guidelines, international guidelines, they're your friends. Amanda's got them on her page. I reference them in my book. I know you do in yours as well. They're easy to find and no doctor should be bothered by you checking their work against national guidelines. I think it's awesome. When someone does that, it tells me that they're engaged and they want to learn. And I have never once that I can remember ever had a difficult conversation with someone who brought in the national guidelines. So maybe that's because that's how it's practiced according to the national guidelines. But, but that's something that your doctor should be like, yes, they brought in the national guidelines. Yeah. It's like that should be the response. And I think it's a great way for people to learn to look at things as well. So,
that's awesome.
All right.
But anyway, Jen, I loved it. That was so great. I could sit and talk to you all day, of course. But and it looks like people have enjoyed it too. So thank you so much. And let's do this again. I mean, there was still a lot of questions we didn't answer, but I think we covered a lot of like the big ones. So I'll save them for next time.
Thank you so much for listening to the show. If you like what you hear, then why not subscribe to this podcast and leave me a review? You see, when you do this, it helps to raise the profile of my show and attract new listeners. And it also allows me to continue to deliver valuable content with great guests. And in return for you doing that, I will send you my 12-week core-focused program called Abs on Fire as a thank you. Simply drop me an email at amanda@amandasteve.com and I'll wing that your way. Bye.